Chapter 62, Caring for Clients with Traumatic Musculoskeletal Injuries. On completion of this chapter, you should be able to differentiate strains, contusions, and sprains, define joint dislocations, discuss the nursing management of various types of sports or work-related injuries, identify the stages of bone healing after a fracture, describe the signs and symptoms of a fracture, explain the nursing management for clients with various types of fractures, discuss methods used to prevent complications associated with fractures, discuss potential complications associated with a fractured hip. A strain is an injury to a muscle when it is stretched or pulled beyond its capacity. A contusion is a soft tissue injury resulting from a blow or blunt trauma. Sprains are injuries to the ligaments surrounding a joint. A strain results from excessive stress, overuse, or overstretching. Small blood vessels in the muscle may rupture, and the muscle fibers sustain tiny tears. There are three types of strains. First degree, mild stretching of the muscle or tendon, causing some edema and muscle spasm, but no real loss of function. Pain occurs with full range of motion. Second degree, partial tearing of the muscle or tendon, leading to inability to bear weight, limited motion, and there is edema, muscle tenderness, muscle spasm, and ecchymosis. Third degree, severe muscle and/or tendon tearing, causing severe pain, muscle spasm, ecchymosis, edema, and loss of function. In contusion, injury is confined to the soft tissues and does not affect the musculoskeletal structure. Many small blood vessels rupture, causing ecchymosis or a hematoma. Applying cold packs help to relieve local pain, swelling, and bruising. A contusion usually resolves within 2 weeks. Areas most subject to sprains are the wrist, elbow, knee, and ankle. A sprain of the cervical spine is commonly called a whiplash injury. Sprains result from sudden unusual movements or stretching around a joint, which is common with falls or other accidental injuries. The force twists the joint in a direction it was not designed for or displaces it beyond its normal range of motion by partially tearing or rupturing the attachment of ligaments. The damage usually is confined to the ligaments and adjacent soft tissue. Types of sprains are differentiated in the following. First degree involves stretching of a ligament, fibers characterized by mild edema, tenderness, and pain if the joint is moved. Second degree involves partial tearing of the ligament with edema, pain with motion, joint instability, and some loss of function. Third degree, the ligament is torn or ruptured completely, with possible detachment of a fragment of bone referred to as a avulsion fracture, and hematoma formation, which contributes to the severe pain, edema, and a normal joint movement. The injured area becomes painful immediately and swelling usually follows. The person typically avoids full weight bearing or using the injured joint or limb. Later, ecchymosis may appear. In cases of extensive ligamental tearing, the joint may be unstable until it heals. In most cases, diagnosis is made by examination of the affected part or symptoms. X-rays may show a larger than usual joint space and rule out or confirm an accompanying fracture. An MRI test may be done to determine the extent of injury. Arthrography demonstrates asymmetry in the joint as a result of the damaged ligaments, or arthroscopy may disclose trauma to the joint capsule. Treatment consists of applying ice or a chemical cold pack to the area to reduce swelling and relieve pain for the first 24 to 48 hours. Elevation of the part and compress with an elastic bandage may also be recommended. The acronym PRICE refers to protection from further injury, rest, ice, compression, and elevation, a method for remembering the treatment for sprains, contusions, and strains. Injured structures must be protected from further injury by immobilization. After 2 days, when swelling no longer is likely to increase, applying heat reduces pain, relieves local edema by improving circulation. Full use of the injured joint is discouraged temporarily. Non-steroidal anti-inflammatory drugs ease discomfort. Continued trauma during healing may result in a permanently unstable joint or the formation of fibrous adhesions that may limit full range of motion. Occasionally, a removable splint or light cast is applied for several weeks. A soft cervical collar limits motion if the client has neck pain. When sufficient healing has occurred, progressive active exercises are prescribed. Question number 1. Is the following statement true or false? An acronym for the appropriate management of strains, contusions, and sprains is RICES. The answer is true. An acronym for the appropriate management of strains, contusion, and sprains is RICES. Rest, ice, compression, elevation, stabilization. Dislocations occur when the articular surfaces of a joint are no longer in contact. The shoulder, hip, and knee are commonly affected. A partial dislocation is referred to as a subluxation. In adults, trauma usually causes dislocation. Occasionally, diseases of the joint results in dislocations. When ligaments supporting a joint are torn, stretched, or relaxed, separation of adjacent bones from their articulating joint interferes with normal use and produces a distorted appearance. The injury may disrupt local blood supply to structures such as joint cartilage, causing degeneration, chronic pain, and restricted movement. Compartment syndrome, a condition in which a structure, such as a tendon or nerve, is constricted in a confined space, may also develop. The syndrome affects nerve innervation, leading to subsequent palsy. If compartment syndrome occurs in an upper extremity, it may lead to Volkmann's contracture, a claw-like deformity of the hand resulting from obstructive arterial blood flow to the forearm and hand. The client is unable to extend his or her fingers and complains of unrelenting pain, particularly if attempting to stretch the hand. There are also signs of compromised circulation to the hand. Another possible complication of dislocations during the healing process involves insufficient deposit of collagen during the repair stage. The end result is that the ligaments may have reduced tensile strength and future instability, leading to recurrent dislocation of the same joint. The client often reports hearing a popping sound when the dislocation occurs. Another common complaint is that the joint suddenly gave out, implying that it became unstable or non-supportive. If the dislocation results from trauma, the client usually experiences considerable pain from the injury and the resultant muscle spasm. On inspection, the structural shape is altered. A depression may be noted at about the joint's circumference, indicating that the bones above and below are no longer aligned. If the dislocation affects an extremity, the arm or leg may be shorter than its effective counterpart as a result of the displacement one of the articulating bones. Range of motion is limited. Evidence of soft tissue injury, including swelling, coolness, numbness, tingling, and pale or dusky color of the distal tissue. X-rays show intact yet malpositioned bones. Arthrography or arthroscopy may reveal damage to the other structures in the joint capsule. So medical and surgical management. The physician manipulates the joint or reduces the displaced parts until they return to normal position, then immobilizes the joint with an elastic bandage, cast, or splint for several weeks. Doing so allows the joint capsule and surrounding ligaments to heal. The client may receive a local or general anesthetic before the manipulation is performed. Some dislocations may require surgical, either to correct the dislocation or repair the damage caused by the injury. Nursing management. The nurse relieves the client's discomfort by administering prescribed analgesics, elevating and immobilizing the affected limb, and applying cold packs to the injury. He or she performs neurovascular assessments every 30 minutes for several hours, and then at least every 2 to 4 for the next 1 to 2 days to detect complications such as compartment syndrome. Client and family teaching is also important as for preventative strategies for sports and work-related activities. Tendonitis is the inflammation of the tendon caused by overuse. There are several types of tendonitis that commonly occur as a result of repeated sports or work activities. Epicondylitis, ganglions, and carpal tunnel syndrome are recurrent injuries that are frequently seen. Epicondylitis, tennis elbow, is a painful inflammation of the elbow. A ganglion cyst is a cystic mass that develops near tendon sheaths and joints of the wrist. Carpal tunnel syndrome is a term for a group of symptoms located in the carpal tunnel of the wrist, a narrow, inelastic canal through which the carpal tendons and medial nerves pass. The primary causes of these injuries are trauma and repeated stress. Injury is also responsible for epicondylitis, which occurs when the tendons of the medial and lateral, radial, and ulnar epicondyles sustain damage. The injury typically follows excessive pronation and supination of the forearm, such as which occurs when playing tennis, pitching a ball, or rowing. Ganglion cysts form through defects in the tendon sheath or joint capsule and occur most commonly in women younger than the age of 50. Carpal tunnel syndrome results from repetitive wrist motion that traumatizes the tendon sheath or ligaments in the carpal tunnel. The trauma produces swelling that compresses the medial nerve against the transverse carpal ligament. Those affected tend to be in occupations that perform repetitive hand movements, such as cashiers, typists, musicians, assemblers, and all those who spend many hours using the keyboard and mouse. The assessment findings. These injuries are marked by pain and inflammation, which can spread to surrounding tissues. In epicondylitis, clients report pain radiating down the dorsal surface of the forearm and a weak grasp. Clients with ganglion cysts experience pain and a tenderness in the affected area. Clients with carpal tunnel syndrome describe burning and pain in one or both hands, which may radiate to the forearm and shoulder in severe cases. The pain tends to be more prominent at night and early in the morning. Shaking the hands may reduce the pain by promoting movement of swelling fluid from the carpal tunnel. Sensation may be lost or reduced in the thumb, index, middle, and a portion of the ring finger. The client may be unable to flex the index and middle fingers to make a fist. Flexion of the wrist usually causes immediate pain and numbness. Diagnostic findings. In general, X-ray studies are used to identify abnormalities and rule out fracture and other problems. In carpal tunnel syndrome, results of a electromyography, which relies on the mild electrical currents to stimulate the nerve, show a delay in the motor response in muscles innervated by the median nerve. Other tests are the Tinel sign, which is a test that elicits tingling, numbness, and pain for clients with carpal tunnel syndrome, and the Phelan sign, which involves having the client flex the wrist for 30 seconds to determine if the pain or numbness occurs. A positive sign for carpal tunnel syndrome. The examiner percusses the median nerve located in the inner aspect of the wrist to elicit this response. Treatment of these disorders include applications of cold and heat, exercise, steroidal anti-inflammatory medications, local injections of corticosteroids, analgesics, NSAID, and rest. Surgical intervention may be necessary to repair tears and ruptures. In many cases, clients with injuries of the shoulder or other portions of the upper extremities are referred for physical therapy. Treatment for epicondylitis may include splinting to rest or support the joint structures. Corticosteroids may be injected locally. Treatment of ganglion cysts includes aspiration of the ganglion, corticosteroid injection, and surgical excision. Carpal tunnel syndrome involves resting the hands when possible and splinting the hand and wrist. NSAIDs and periodic injection of corticosteroid preparation may relieve the inflammation and discomfort. If conservative treatment fails, surgery to release the pressure of the ligament on the median nerve may be performed. Nursing management. The nurse provides information about medications. If the client is taking NSAID, the nurse stresses to take these medications with food. If corticosteroid injections are ordered, he or she explains what the client can expect and mentions that the injection itself may cause some discomfort. The nurse shows clients how to use and care prescribed splints and performed related range of motion exercises. Some clients find that the hand exercises are less painful if performed with the hand under warm water. Additional management activities involve exploring ways to perform activities of daily living or alter job responsibilities to relieve stress and reduce injury to joints. Key teaching points include the following. Rest the joint in a position that reduces stress. Support the affected arm joint on pillows while sleeping. Apply cold for the first 24 to 48 hours to reduce swelling and pain. Gradually increase joint movement. Avoid working or lifting above the shoulder level. Do not push objects with the arm joint particularly the shoulder. Perform range of motion and strengthening exercises as prescribed by the physician or physical therapist. Question number 2. Is the following statement true or false? Rest is an important facet of the medical treatment of tendonitis. The answer is true. Rest is an important facet of the medical treatment of tendonitis. Resting the affected tendon is the first necessary step in medical treatment. Without rest, other treatment modalities will have little success. The rotator cuff is made up of 4 muscles and their tendons that connect the proximal humerus, clavicle, and scapula, which in turn connect with the sternum and ribs. Rotator cuff injuries can occur as a result of a traumatic injury or from chronic overuse or irritation of the shoulder joint. A tear occurs in a tendon connecting to the rotator cuff to the head of the humerus. Tears are differentiated as partial or full thickness. Clients experience pain with movement or limited mobility of the shoulder and arm. They especially have difficulty with activities that involve stretching their arms above their heads. Many clients find that the pain is worse at night and that they are unable to sleep on the affected side. The diagnosis is based on physical examination. Generally, there is tenderness on the acromoclavicle joint. Radiography, arthrography, ultrasound, and MRI can evaluate the extent of the rotator cuff tear and any soft tissue injury. Initial treatment begins with the use of NSAIDs. The physician will advise clients to modify their activities and to rest the joint. Physician may also recommend corticosteroid injection into the shoulder joint, with progressive, passive, and active exercising and stretching. Surgical procedures include the following: an arthroscopic tendon repair, where they reattach the tendon to the bone arthroscopically. Open tendon repair, a larger incision is used to repair and reattach the tendon. Removal of the bone spur, excess bone is removed and tendons are repaired through a small incision. A tendon transfer, replace torn tendons with the nearby tendon, open procedure. A shoulder replacement, referred to as a reverse shoulder arthroplasty. The socket portion of the artificial joint is placed on the humerus, and the ball part of the joint is placed on the scapula. Depending on the type of surgery, clients have to immobilize the shoulder for several days to several or more weeks, and then undergo physical therapy for several weeks to months. Clients generally will have full recovery postoperatively within 6 to 12 months. Ligament and meniscal injuries to the knee occur as a result of a traumatic injury. Injuries can occur to the lateral or medial collateral knee ligaments, or to the anterior cruciate ligament, ACL, or posterior cruciate ligament, PCL. These ligaments provide stability to forward and backward movements. In addition, menisci can become injured, disrupting the stability of the leg when flexed or extended. Injury to the ligaments of the knee occur at a time when the client is standing firmly and receives a blow or twist in a different direction while hyperextending the knee. The client experiences pain, instability of the joint, and ambulating difficulty. When the ACL or PCL tear, the client may report a popping sound or tearing sensation. Meniscal injuries occur when the twisting of the knee or repeated squatting. Clients report that their knees gave way or buckled, and clients may experience a click in their knees as they ambulate. Some instances, the knee locks because the cartilage moves as it tears and prevents full flexion and extension. An MRI initially may be done to assess the extent of injury. Treatment depends on the extent of injury. Initial treatment involves immobilizing the joint and limiting weight bearing. The physician may recommend NSAIDs as well as the use of ice during the first 48 hours. Gradual induction of activity assists the client to progress without causing further injuries. Surgical procedures include repair of the ligaments and tendons involved. An arthrocentesis may be done for diagnostic purposes and to provide symptomatic relief through drainage of bloody fluid. An arthroscopy is done to determine what the meniscal tear involves. For torn menisci, the surgeon removes the damaged cartilage. Following surgery, the physician will immobilize the joint, prescribe NSAIDs, and recommend the application of cold therapy. Physical rehabilitation includes exercises, gradual weight bearing, and the use of an ambulatory device. Recovery is generally complete within 3 to 12 months, depending on the nature and injury and the type of surgery. Rupture of the Achilles tendon occurs secondary to trauma. As the client engages in an activity, the calf muscle contracts suddenly, while the foot is grounded firmly in place. There is often a loud pop, and the client experiences severe pain and inability to plant or flex the affected foot. The client usually requires surgical repair for complete healing to occur. Following surgery, the client wears a cast or brace for 6 to 8 weeks. Physical therapy is necessary for the client to regain mobility, strength, and full range of motion. The nurse teaches the client about activity restrictions and the use of ambulatory aids and pain management. Clients who have surgery need to have preoperative and postoperative instructions. Question number 3. Is the following statement true or false? Many clients who rupture their Achilles tendon report hearing a loud pop at the time of injury. The answer is true. Many clients who rupture their Achilles tendons report hearing a loud pop at the time of injury. The report is often a significant symptom accompanied with severe pain. A fracture is a break in the continuity of a bone. Fractures may affect tissues or organs near the bones as well. Fractures are classified according to the type and extent. An avulsion is a pulling away a fragment bone by a ligament or tendon and its attachment. A compound fracture is a fracture in which damage also involves the skin or mucous membranes. A green stick fracture is a fracture in which one side of the bone is broken and the other side is bent. A simple fracture is a fracture that remains contained, does not break the skin. A spiral fracture is a fracture twisting around the shaft of the bone. See the image for additional types of fractures. Assessment findings. The signs and symptoms of fracture may vary depending on the type and location. They include the following. Pain. One of the most consistent symptoms of a fracture is pain, which may be severe. Attempts to move the part or pressure over the fracture contribute to increased pain. Loss of function. Skeletal muscular function depends on intact bone. Deformity. A break may cause an extremity to bend backward or to assume another unusual position. False motion. Unnatural motion occurs at the site of the fracture. Crepitus. The grating sound of the bone ends moving over one another may be audible. Edema. Swelling usually is the greatest directly over the fracture. Spasms. Muscle near fractures involuntarily contract. Spasm, which accounts for some of the pain, may cause a limb to shorten when the fracture involves a long bone. If sharp bone fragments tear through sufficient surrounding soft tissue, there is bleeding and black and blue discoloration of the area. If a nerve is damaged, paralysis may result. For 10 to 40 minutes after a bone breaks, the muscles surrounding the bone are flaccid. Then they go into spasm, often increasing deformity and interfering with the vascular and lymphatic circulations. The tissue surrounding the fracture swells from hemorrhage and edema. Healing begins when the blood in the area clots and a fibrin network forms between the broken bone ends. The fibrin network changes into granulation tissue. Osteoblasts, which proliferate into the clot, increase the secretion of an enzyme that restores the alkaline pH. As a result, calcium is deposited and a true bone forms. The healing mass is called a callus. It holds the ends of the bone together but cannot endure strain. Bone repair is a local process. About 1 year of healing must pass before bone regains its former structural strength, becomes well consolidated and remodeled, and possesses fat and bone marrow cells. This image shows the process of bone healing. In letter A, immediately after a bone fracture, blood seeps into the area and a hematoma clot forms. B, after 1 week, osteoblast forms as the clot retracts. After about 3 weeks, a procalculus forms and stabilizes the fracture. C, a callus with a bone cells forms in 6 to 12 weeks. In 3 to 4 months, osteoblasts begin to remodel the fracture site. D, if the fracture bone has been accurately aligned during healing, remodeling will be complete in about 12 months. Although fractures are common, they are associated with various complications, particularly when they are very complex. These complications include compartment syndrome, thromboembolism, fat embolism, delayed healing, non-union, malunion, infection, and avascular necrosis, death of the bone from an insufficient blood supply. In addition, any client who is inactive during convalescence is prone to pneumonia, thrombophlebitis, pressure sores, urinary tract infection, renal calculi, constipation, muscular atrophy, weight gain, and depression. Older adults are more prone to skeletal fractures because bone reabsorption takes place more rapidly than bone formation. One or more radiographic views of the area almost always demonstrate altered bone structure. Stress fractures may not be apparent radiographically for a few weeks. A bone scan usually can identify a non-displaced or stressed fracture before radiographic changes are evident. In some cases, a MRI or CT scan may be necessary. Medical and surgical management. The goal is to reestablish functional continuity of the bone. Treatment includes one or more methods: traction, closed or open reduction, internal or external fixation, or cast application. The treatment method depends on many factors, including the first aid given, the location and severity of the break, and the age and overall physical condition of the client. Nursing management. When caring for the client with a fracture, the nurse assesses them for neurovascular and systemic complications. General nursing measures include administering analgesics, providing comfort measures, assisting with ADLs, preventing constipation, promoting physical mobility, preventing infection, maintaining skin integrity, and preparing client for self-care. Because the client may be discharged shortly after application of an immobilization device or cast, the nurse reviews care with the client and family. In addition, he or she reinforces instructions regarding exercise and ambulatory activities. If a client is in traction, he or she requires simple and direct explanations about the traction and its purpose. The nurse points out activities that are allowed or contraindicated and identifies the approximate duration of the restrictions. When traction is discontinued, the nurse prepares the client for further treatment, such as casting, or for the appearance of the affected area, skin, and muscles. He or she reassures the client that with gradual exercise and use, muscles will regain strength and tone, and joints will be flexible. A hip fracture affects the proximal end of the femur. This type of fracture commonly results from a fall or occurs more frequently in older adults with osteoporosis. Usually the falls are not very traumatic, but the client's condition contributes to the resulting fracture. Fractures may occur in the femoral neck because the trochanters or below the trochanters. The client reports severe pain that increases with leg movement. The pain frequently radiates to the knee, and the client may have a sensation of pressure in the outer aspect of the hip. Discontinuity of the bone and muscle spasm cause shortening and external rotation of the leg. A large blood loss may accompany subtrochanteric and introchanteric fractures, leading to hypovolemic shock. There may also be extensive bruising and swelling in the hip, groin, and thigh. Femoral neck fractures are intracapsular, so bleeding is more likely to be contained within the joint capsule. Radiographic studies reveal the exact location of the fracture, which may be within or outside the joint capsule. Intercapsular hip fractures are prone to non-union or avascular necrosis from the disrupted blood supply. Therefore, the fractured head and neck may be removed and replaced with a metal device such as an Austin Moore or Thompson prosthesis. This procedure is referred to a hemiarthroplasty. The bone heals around the metallic device, which in the meantime holds the bone together. Thus, the bone is united immediately, and the clients are mobilized much earlier than they are with traction. Plates, bands, screws, and pins may be removed after the bone has healed. More often, they are left in place permanently. The precautions with a hemiarthroplasty are greater because the surgeon must dislocate the hip to replace the femoral head. Clients who have a total hip arthroplasty. Most clients with a fractured hip are older adults and are prone to complications. After surgery, the nurse implements measures to prevent skin breakdown, wound infections, pneumonia, constipation, urinary retention, muscular atrophy, and contractures. The client usually has a wound drain in place for 1 to 2 days after surgery. The nurse monitors the drainage and administers antibiotics as prescribed. The nurse must show the client how to use the overhead trapeze safely for independent movement and activity. When the client is recumbent, the nurse places a trochanter roll beside the hip to maintain a neutral position so that the repaired hip stays in place. He or she places abductor pillows between the client's legs when turning the client from side to side. If the hip prosthesis has been inserted, the nurse instructs the client to avoid adduction of the affected leg until it has healed. The client must use abductor pillows at all times. Soon after surgery, the nurse or physical therapist assists the client to transfer from the bed to chair. The chair must have an elevated seat, either with its structure or with pillows, so that the client does not flex the hips beyond 90 degrees. The client usually requires much encouragement and assistance. Eventually, the client progresses to ambulating with the walker. Before discharge, the nurse needs to explore ways to ensure safety in the client's home to avoid future injuries and falls. This concludes our lecture on Chapter 62, Caring for Clients with Traumatic Musculoskeletal Injuries.